Welcome everyone to today's webinar. I am Anuja Vaidya with Beckles Hospital Review. We will begin today's webinar with a presentation and we'll have time at the end of the hour for a question and answer session. You can submit any questions you have throughout the webinar by typing them into your control panel in the space labeled Enter a Question for Staff and click Send. We are looking forward to hearing your questions. Additionally, in about a week following the webinar, we will be sending you a copy of the presentation to the email you used to register. At this time, it is now my pleasure to start today's webinar by introducing our presenters. Dr. Kristen Baim is a senior advisor at Nexera. Her responsibilities include leading in value analysis programs at multiple client sites. Using Nexera's physician-led approach, Dr. Baim facilitates physician engagement and the integration of value-driven decision-making in new models of healthcare delivery systems. She has been a key player in launching several value analysis programs at several regional hospitals, as well as championing the process for client organizations that are interested in change management strategies. Jeff Ashkenazi oversees the value analysis, sterile processing, and workforce and management solution services at Nexera. Mr. Ashkenazi has worked in the healthcare industry for more than 20 years in the nonprofit, managed care, group purchasing, and government settings. Throughout his career, he has been responsible for managing costs, system implementation, optimizing the supply chain, and improving decision support and the budgeting process through the use of technology. Jeff and Dr. Baim, I'll now turn the floor over to you to begin today's presentation.
Thank you, and thank you everyone for taking the time today for attending our presentation, First Steps to Integrating Clinical Pathways. One of the most significant or beneficial steps in an affiliation or a merger is the integration of clinical pathways or operations. Today we're going to talk about what the first steps are and the things that you need to consider to make sure that you have the right foundation in place for the integration of clinical pathways and operations. We're going to cover a number of things today, and I'm going to start by providing some background information about the landscape and the prevalence of mergers and acquisitions and affiliations and what we're seeing in the industry today. Then we're going to talk a little bit about what organizations hope to achieve by these actions. And this is really important, and I'll touch on it more later. It's important to understand what the goals and objectives are and make sure they align with your goals about getting the benefits of clinical integration and integrating clinical operations. I'm going to discuss it through the use of some examples, keys to success and potential pitfalls to look out for in these processes of integration. And then I'm going to turn it over to Dr. Baim to talk about working with clinical leadership and the impact of clinical integration, the impact that will have on cost, quality, and outcomes. So as I mentioned, I'm going to start with the market trends and planning ahead. For the majority of the hospitals, alignment is at least a consideration in their strategic plans. The American Hospital Association indicates that since 1999, the number of hospitals has only increased 1%, while the number of hospitals that are in a system or have affiliated have increased 16%, from 2,500 to about 2,900. So as you can see, this has been going on for a number of years, and as we look at what's going on in the landscape and some of the competitive pressures, we see this trend not only remaining the same, but increasing, and the number of system integrations really increasing. And that's really due to the increasing margin pressure from government and some of the regulatory reforms. And that's because hospital mergers provide the scale necessary to achieve operating efficiencies for hospitals to come together and operate in this area. Today's healthcare landscape has moved away from encounter-based reimbursement and adopted new payment models that reward coordination of care and population health management. These newly formed hospital alliances have a choice on how they'd like to work together. They can elect to change nothing around clinical behavior and operate independently. They can maintain their current strategies that have allowed them to thrive in a fee-for-service environment and not really focus on coordination of care. But if they do those things, they're going to feel the impact of declining reimbursement, declining physician reimbursement, and lower profit margins. Or what we see more and more organizations do, or what's really driving a lot of these affiliations, is they clinically integrate. The benefits of clinical integration offer the hospitals and the physicians the opportunity to coordinate patient interventions, manage quality across the continuum of care, move toward population health management, and pursue true value-based contracting. Ultimately, the path to clinical integration is far from clear. The best strategy is to build a platform for hospital-physician collaboration, both in an individual hospital and a system that's flexible enough to support a broad range of possible futures. Funding costs and financial considerations are often big factors for a merger or acquisition. The upside of bringing systems together can be easily undermined if the merger is not handled well, and you are not prepared to deal with previously unidentified problems. These types of pitfalls can really offset a lot of the financial or expected benefits, erode clinician and staff morale. It's pretty tricky to bring two organizations together. It's more than just bringing them together and putting up a new sign. And when evaluating what you hope to accomplish, clinical integration is being more and more seen as success, and what the end goal is, more so than just financial improvement. Moving on to driving forces of integration. Organizations merge for a number of reasons. In some cases, they merge, as I had mentioned, and we've seen a lot historically, it's just purely financial. And when I say everything that a hospital does or a system does to come together provides a financial benefit. But in this instance, I'm really just talking about improving reimbursement and reducing expenses by leveraging their new economies or their new scale. So they're a bigger organization, they have more leverage with a managed care company, or they're a bigger organization and they have more leverage with a supplier. So really taking advantage of those economies of scale. And that's been driving a lot of mergers that we've seen historically. What we're starting to see more and more of, and over the past couple of years, and where we expect the trend to continue, and organizations are acquiring or affiliating with other organizations to get something else to enhance their current situation, possibly to expand their geographic reach, acquire a strong or diverse physician network with a larger geographic reach, rationalize clinical service lines or clinical services with another organization. And in some cases, especially in some urban areas, it's really a purely defensive strategy, and organizations are integrating or merging to prevent that organizations from being acquired by a competitor. The drivers are what's important to the organization when they identify the need to merge. Is usually part of a strategic plan to help the organization thrive in the new healthcare environment. It's not only important to understand what's driving the integration, but understand the timeline for the integration. So in addition to being familiar with why your organization merged, you really need to understand how those drivers affect some of the decisions that are going to be made or some of the priorities going forward. For example, if during the initial discussions there was no mention about integrating clinically, and it was all about leveraging size and scale from a payer or a supplier contract perspective, there's going to be more and more of a challenge of bringing the physicians and the clinicians along and integrating their operations or their pathways, because that wasn't an initial driver. And so how you stage that and how you time that would be very different. But if the reason for your merger or the integration really stemmed from the fact that you wanted to acquire services that you didn't have today, or expand your geographic reach through the acquisition or partnering with a set of physician practices, clinical integration, as well as those other things that I've mentioned before, would probably be at the forefront of your planning. So all organizations partner for different reasons, and there are different makeups of the different types of organizations that come together. On this slide, I just share some of the different situations that we've been working with, or systems that we've been working with. large academic medical centers and community hospitals. In some cases, the community hospitals are doing well financially. In some cases, they're not. Large urban academic medical centers and other types of university-affiliated medical centers. Large health systems and various integrated affiliates. So they might be working with more than one hospital. Some are in better financial shape than others. Some are clinically integrated than others. And, large urban academic medical centers and their affiliates and what they consider their integrated affiliates. And I'll talk a little bit about that later, about why some people are calling themselves integrated systems but really aren't. While the makeup of all these organizations are different, there are really a lot of similarities, or there are some similarities that you can see in between them. The first one is the improved ability to provide care. There are lots of constituents that they have to deal with when these organizations come together, both internally and externally. Sometimes there's a burning platform for these affiliations, and sometimes there's not. But most importantly, what's important is planning for this kind of change. So moving forward to keys to success, or things to consider when you're affiliating. I touched on it earlier, but really one of the most important things that will drive a lot of your ability to be successful or evaluate whether you're successful is really understanding what your focus is or what the key driver is. Are you purely seeking economies of scale? Are you drawing on some clinical or unique managerial strength or clinical strength of the other organization? Or are you looking to gain geographic strength to better serve a patient or community need? Other things that are important or things to consider is what's your legal and operational structure? There are lots of ways that organizations come together, and there are lots of ways that organizations call what they're doing. There's consolidations, mergers, joint ventures, joint operating agreements, and clinical affiliations, or just straight acquisitions. So all of those things bring different challenges and bring different opportunities, and understanding what kind of structure you have and what your limitations and your opportunities are will help you move forward, especially when you start to talk about what kind of clinical integration you have. What the governance structure is another important consideration when you're looking at your structure. And finally, from a more informal point of view, it's not only who formally has the governance, but who are the influencers? Who are the key physicians? Who are the key administrators? Who are the key community leaders that will help these mergers be successful and help you achieve your goals? Another important consideration is the timeline. There are pros and cons to a rapid integration or more incremental integration, where you're moving different components together over a longer period of time. And depending upon what you do or what path you take, that will drive your ability to integrate clinically or to get the benefits of clinical integrations. You'll have to look at which systems you integrate. Will you be consolidating your medical staff? And the rationalization of services between the organizations. And not only will you be doing it, when you will be doing it. The other thing that take into consideration is your historical experience. In many cases, the coming together of a system will not be the first time that you've tried to affiliate with another organization, or the other organization may have had an experience in the past. So understanding what those experiences were, a positive, negative, what the drivers of those experiences were, and what you could learn from those will really help you be more successful in the future. One of the most important things about an integration or an affiliation, or one of the biggest enablers, is technology. I don't think I'm saying anything that people don't understand. So the more that you're able to integrate your technology or align the technology, the better able you are to monitor performance, track your initiatives, standardize processes. And this is going to be different for every organization, and it's important to realistically assess what you can do both from a financial standpoint and from a resource standpoint. How many changes that you could make in a short period of time is going to be important. because you probably can't make all the changes that you want to make. And so you don't want to assume that you're going to move faster towards integration, especially integration, clinical integration, than the resources and the people allow. Later on in the presentation, Dr. Boehm is going to talk a little bit about organizational culture and a little bit more about clinical integration, but I just wanted to touch on some of the back office type functions or the system functions that are really enablers or will allow you to really maximize that clinical integration. So moving forward to potential strategies and challenges. It's not, as I said earlier, creating a system is not just about putting up a new sign. It's really a huge multifaceted change management exercise. And so with any change, there are a number of things that you have to consider. And these things really will influence your ability to, and how you address these issues, will influence your ability to integrate clinical pathways and operations. The first thing that we see is when organizations evaluate a partner or starting the integration process, sometimes they forget that decisions that the organization made or processes that they have were really based on the historical situation. And they were made based on the best available resources that the organization had and the best available information that they had. And so don't always think that they're wedded to those types of processes or systems, but also recognize that they've been operating with them for a long period of time. They are used to them, and change is going to be challenging. Also assuming that if they had different technology or different financial opportunities, or there were different other staffing needs or different staffing paradigms, that they would do things the way that they did now. Just assuming that with additional resources, they would do things the same way is probably a mistake. And again, especially when it's a large organization that's financially viable, taking over a smaller organization, judging them based on these historical decisions is really going to be counterproductive to what you're trying to do. The other thing that happens in these types of situations is during the initial stages of discussions, and even in the initial aftermath of the post-affiliation, everyone is feeling out the situation. And in many cases, people are worried about how they're going to fit into the new organization or even their jobs. And you might think about this in the back office functions, accounts payable, biomed, environmental services, and areas like that. But those kind of concerns also hold true to clinicians. And how you deal with that and how you address that is going to be important in understanding how you're going to integrate clinical operations. Initially, because of everyone's fear about whether they're going to have a job or they're going to have a role, initial discussions may go smoothly. And if they do, that's great. But you're probably going to avoid issues or challenges that you need to address. So while things might be going along very smoothly initially, as time goes by, if you haven't addressed those bigger issues about are we going to have one chair or two chairs, or are we going to integrate our systems, or how are we going to measure outcomes, or how do we define what quality is, down the road when you start to integrate clinical operations, you're going to have to address them, and that's going to become more challenging. Conversely, if you address those issues, those harder challenges early on, making some of those decisions later on might be easier. Again, those are decisions that you could make about when you want to address those types of challenges. And the other thing is, while we always think the reduction of variability or standardization is positive and provides benefit, at the end of the day, we have to realize that 100% standardization or synchronization might not be the best. There are definitely some legitimate reasons for processes or governance structures to be different. They could be technology differences, what you have access to or what your technology could do, differences in patient population, differences in physical space that cannot be underestimated. How much does the physical plant impacts your ability to standardize clinical operations? the type of legacy equipment or technology you have. Those are all valid reasons preventing standardization in clinical operations. And the questions that you have to address is, how do you want to mitigate those issues? Do you want to just work through them, or do you want to try to standardize? And over what period of time are you going to start to mitigate those issues? And a really realistic assessment and not trying to skip over steps is key into the determination of how you're going to be able to integrate your clinical pathways or clinical operations. So next, I want to provide some examples about some of the things that we've seen and use those to talk about some of the challenges and address some of those issues that I brought up earlier. So the first example is this is an example of a financially strong academic medical center taking over struggling community hospital. It was a full asset merger, and within 8 months of the effective date, they had integrated both the financial and clinical systems. The drivers for the academic medical center was they wanted to expand their area geographically, and they wanted access to a different type of patient population that benefited them financially. The academic medical center, as I mentioned earlier, was financially strong and invested heavily in this merger. What was attractive to the community hospital was the capital and the upgraded technology. It gave them the opportunity to enhance the care and services they were able to provide in ways that they would never have been able to do it on their own. But since this was a new patient population for the academic medical center, the folks at the community hospital were concerned about how this would impact their ability to fulfill their mission. And so that was one of the things that they spent a lot of time talking through initially, not only with the staff and the clinicians of the organization, but the community leaders. It was an important part of their process. And it really went a long way in reassuring both the patients and the staff that while the academic medical center was bringing additional resources and additional expertise, they weren't necessarily going to steamroll or take for granted what had made the community hospital so special in the first place. Initially, and during even though it was a very rapid implementation of all the technology, there were lots of discovery conversations and lots of questions were asked and discussed regarding policies, processes, and operations. But as we got further through the integration, we realized that even though we had spent a lot of time talking about how things operated and how things could be brought together, we identified many more items that needed to be addressed. And maybe I shouldn't characterize it as many more items, but the significance of some items that we thought were minor when we originally had our conversations took on a much greater role. And it really was as a result of both organizations looking at information that they hadn't looked at before, looking at it in different ways than they've looked at it before. And it was really sort of an opportunity to evaluate the operations of both organizations. And a lot of the changes or a lot of the things that came to light were not necessarily only things that were occurring at the community hospital. The academic medical center really took the opportunity to evaluate some of the historical decisions that they made and challenge some of the ways that they were doing business. Not only just because they had the opportunity, but because in light of the new structure and the new integration and the new way the organizations were sharing staff, maybe different decisions needed to be made. There were a couple of things that I think you have to take into consideration. Also, one is if you've been operating in an organization for a long period of time, to a certain degree, you're used to the way that things operate. You're just view some of the technology or some of the processes as just sort of commonplace. And you have a tendency to forget what it was like moving from, let's say, a paper-based to a paperless environment. And so it really takes effort to go back and say, what did it feel like for me when I made all these changes? What did it feel like for me when I was asked to operate differently from a clinical pathway perspective? What difference, how did I feel when all of a sudden the results, my either outcomes, my length of stay, my infection rates, my adherence to pathways was starting to become visible to others in the organization? And so if everyone looks at it, how it made them feel individually, and then applies that to how it would feel for a whole organization, I think that that's something important, and that's something that you could take for granted, especially when you think about it in the light of organizations are operating the way that they were operating based on typically historical constraints. And so you shouldn't use that opportunity or use this or judge people on it. Just understand why those decisions were made. The other thing that happened in this case was the community hospital was very excited, or felt that there was a lot of possibilities for them or opportunities for them by being acquired by this large academic medical center. And so one of the things they did is they started to stop some of the processes that they had very quickly after the affiliation, with the expectation they would just be picked up and integrated into the larger organization. The community hospital had a very strong and robust physician-led value analysis group. And what they assumed was that now that they were being acquired by this large academic medical center, that their work would just be folded into the large academic medical center's processes. But because of things like they hadn't integrated technology, they haven't really worked out the governance structure yet. Would there be 2 chairmen, 1 chairperson? Those chair people were still feeling each other out to understand how to work together. What we ended up doing was stopping value analysis work at this community hospital and not substituting it with any other value or any other process. And it really left a hole in their operations. And we've since had to restart their committees and their decision-making process while the rest of the organization and the rest of the changes within the organization caught up to that. Now, that's not ideal, and it really was a lesson learned for all the organizations as they start to look at other affiliations about how to sequence things and how to time things. And maybe just because things are the easiest to integrate up front, they might not be the best things to integrate up front. Another example that I want to share, or another is, again, the legal structure for this is very similar to what I just spoke about. It was a large academic medical center acquiring another community health center, or another academic community health center. The reasons for this integration was a little bit different. The drivers were about, for one organization, expanding the geographic footprint. For the other one, it was about getting access to specialists that they didn't have in their own 4 walls and had to refer out to other organizations. There was the integration of other complementary services. One organization had a much stronger cardiac program than ortho program, and the other organization vice versa. There was a large physician network that now would have access to many more acute day services than they had before. And so while the first example was really a rapid integration, this is one that I would characterize as that they've decided to get engaged, but they haven't picked a wedding date yet. And so they're moving a little bit more cautiously. They were both in affiliations before, and they have some experiences that they're trying to learn from. They're really focused on the integration of the technology is going to be farther down the road. They've both recently implemented different clinical electronic medical records, so the ability to integrate clinical pathways is going to have to take on a much different process. Initially, because of some of those issues with different clinical systems, there's more of a focus on integrating the non-clinical functions in the short term, while still using the existing clinical structures within each organization for decision-making. And their initial goal was about working together and getting some successes and building on them. And like I said, they haven't set a wedding date. So to the extent that they could move forward, create some successes, both either clinically or non-clinically, they'll start to evaluate some of the different options that they have. But in this case, clinical integration is going to be much more challenging, and the alignment of clinical pathways because of the different systems. So again, that wasn't a driver for this organization, integrating clinical pathways, but there were other clinical benefits. The next example that I have is, and this example is more about a group of hospitals coming together to work together than any one hospital, what I'll call being the anchor hospital. They were looking for ways to compete with some of these larger systems, but didn't want to be acquired by these larger systems. And while there were a lot of benefits that they could realize, it did pose some additional challenges for them. Their goals were to expand the footprint of their services, really gain some economies of scale that the larger systems had. But right off the bat, they were really a system in name only. They weren't really clinically integrated, and they were very slow and have been very slow in developing the path for clinical integration. They decided to take the approach of, let's focus on the back office integration. Let's, over time, as we have the ability to make resource decisions about single systems or single platforms or single services, move towards that, and really develop a solid non-clinical background before they move on to clinical integration. And while every once in a while there'll be an opportunity where we can say, well, let's buy this piece of equipment or this robot or this piece of imaging equipment for the system, and from a financial perspective, it makes a lot of sense. There are times where we have to say, we understand from a financial perspective that makes sense, but we're not clinically integrated enough to utilize that piece of equipment or make that decision in that way. So this is an example of really where the process is taking much longer, and clinical integration is something that they're thinking on really down the road. Next, I'm going to turn it over to Dr. Bain so she can talk a little bit about rationalizing the approach, a rational approach for developing clinical leadership.
Okay, thank you, Jeff. So we're going to switch gears a little bit, and I'm going to be in the second half of the program talking a bit about how clinical leadership and organizational culture can fit into this era of mergers and acquisitions. Okay, so I'm trying to advance the slide. So it turns out, Jeff, are you able to advance the slide for me, or?
No, let me try again. Sorry, everyone. You want to try it now,
well,
Dr. Bain?
Sure. Let's see here. Okay, we're having a little technical difficulty. If you're able to advance it, Jeff, that's just fine. I'll just continue on, and maybe the slide will come on over. So
I got it now.
Okay, thank you. Okay. About half of all terminated transactions really cite culture as the primary reason for that. And this can be especially true if the transaction combines very culturally different organizations. So, for example, a for-profit institution merging with a not-for-profit institution, or a faith-based institution combining with a non-faith-based one. And so it's really important to understand at the onset how the cultures of the two organizations will interact, both positively and negatively. And it turns out that even cultures that are dissimilar can commingle, but it's a question of being prepared for the challenges that are inevitably going to come. So naturally, the way to offset this is to create a unified message around the organizational goals and mission. Intertwined with this is the creation of a single administrative hierarchy that is just helpful to avoid confusion as to who's in charge in this time of transition. And these chosen C-suite executives need to develop a vision to share with the organization so that everyone involved in the transformation can get on the same page from the onset. And this dedicated group of executives then need to visibly support the new message and really cement the processes that play a role in ensuring compliance at the local, regional, and corporate levels. This type of support needs to be consistent and it needs to be visible. And by that I mean it extends beyond a mere token nod from the executive office. What it really incorporates is ongoing dialogue, education of the staff and clinicians, alignment, and a certain willingness to vocalize and communicate support for those who may need to challenge the status quo and break down what are current barriers to help attain future defined objectives. So Jeff, if you could advance the slide. So part of this is going to include self-reflection and preliminary due diligence. It's advantageous to identify the financial and cultural barriers that may exist and to spend some time on assessing how an identified partner fits with that other organization. Efforts should be directed toward identifying potential governance structures of the new entity, preparing financial projections, and understanding the organization's shared vision for the future. Only once the current and the future states of the proposed transaction are adequately understood and developed can you then really set in motion the deployment phase. So establishing the new entity and its governance structure, accountability planning, operational planning, and process development are really going to be centerpieces of that then deployment phase. Okay, next slide. So when we're talking about new missions or aligned goals, ultimately, any new hospital alignment is going to have to embed itself in the evolving principles of healthcare as a whole. Recent years have seen a shift in our healthcare delivery system away from episodic care and more towards steps that optimize global health system performance. So this new triple aim of healthcare reform centers on improving the patient experience of care from both quality and satisfaction, improving the health of populations, and reducing the per capita costs of healthcare. Simply put, it requires healthcare organizations to improve the individual's healthcare experience while simultaneously improving the overall health status of groups of people, whether they're grouped geographically or by their disease state. And all of this is occurring simultaneously with reducing costs. So next slide, please. To achieve the triple aim and higher value, healthcare systems will now have to assume greater responsibility for the populations that they're serving. They will have to move beyond silos of treatment that approach disease by disease or an episode of care by an episode of care. And instead now, they're going to need to treat the whole person with an eye to aligning micro and macro system processes, both within and across provider locations and provider types. They're going to need to measure, promote, and reward system processes that facilitate the best chances for successful health outcomes in a framework of shared accountability. So a value-based approach to healthcare is one that is proactive in disease management, it's population-focused, it's outcomes-based, and it's cost-effective. Okay, we can advance the slide, please. So, as Jeff has mentioned, recall that with a merger and acquisition, we're asking sometimes very disparate institutions to standardize operations, focusing on reducing organization-wide operating expenses while maintaining or even ideally improving quality. Key to this then is physicians who can build that clinical roadmap for system change. A merging system won't survive without an engaged provider network that believes in the overarching mission, but that is also intimately involved in fulfilling traditional clinician roles related to quality, patient management, and care management, now with a team-based focus. These functions really form the backbone of the care delivery model as it shifts to population health management. The physicians that can create and communicate this may not always be the same ones that are selected to chair a department. Or in the case of emerging hospitals, they may not necessarily be the physicians from the larger institution or from the academic powerhouse. It's important, therefore, to recognize that different physician leaders can serve very different needs. Ideally suited physicians are no longer simply representatives of their specific clinical department, but rather they function as liaisons with clinical backgrounds who help foster dialogue. They build understanding and comprehensive consideration to process development. Somebody who can facilitate the representation of critical information and really foster shared participation, collaboration, and physician-level peer-to-peer dialogue is going to prove invaluable in these future states. And therefore, careful consideration should be given to who can best balance being a worthwhile clinician with simultaneously serving as a value strategist. Next slide, please. So nowadays, it's worth the effort to seek out frontline physician leaders who not only provide valuable input, but forge linkages to others who must embrace new tenets around the organization and the triple aim. So a good physician champion operates more as a democratic manager and is satisfied being an influencer among their colleagues rather than being a renowned leader in their specialty. They are respected by their peers not only for their clinical acumen, but for their diplomacy and their willingness to listen. They enjoy the collegiality of working with their peers, both in their chosen specialty as well as across other specialties. They are the ultimate team player with an ability to be assertive and not authoritarian. They possess this intangible quality, which you could perhaps call charisma, to effectively persuade their comrades to change their practice patterns. So now we're going to talk a little bit about, we've discussed alignment and getting physicians on board, and this is going to segue into clinical integration and its intimate role with CQO. Okay, and the next slide, please. So new care delivery and payment models, as well as payment penalties, aim to increasingly tie provider reimbursement to the quality of care delivered, instead of what has heretofore been the number of visits or the number of tests ordered. And so while commendable, these changes, along with other healthcare cuts that we're seeing, have equated to continuous hits to providers' bottom line. If providers don't meet specified quality thresholds, they're going to see decreases to their reimbursement. And so by turn, if they're not careful, an institution could be putting more costs into an episode of care than they're going to be getting paid for it. So providers must now look at all costs associated with delivering patient care and weigh these against quality and outcomes data in order to improve the financial viability of their institution in the new healthcare environment. So this approach, which is called CQO, Cost, Quality, and Outcomes, naturally creates a framework for newly created hospital systems to break down barriers and meet the industry objectives of improving the quality and the affordability of healthcare. So we know, next slide please. We know that physician decisions control 70 cents of every dollar spent within the healthcare delivery system. So if we're looking to provide more valuable care at a lower cost, we need physicians fully engaged. And so enter the premise of clinical integration. Clinical integration is teamwork among healthcare providers working to ensure that patients get the right care at the right time in the right setting. Clinically integrated care management teams collaborate across specialties and across many locations, such as adult daycare centers or assisted living centers and skilled nursing facilities. They work with infrastructure focused on supporting caregivers and patients to most efficiently assess, document, communicate, and meet patient needs more holistically. Hospitals can involve physicians in improving care through clinical integration by forming a collaborative network of providers following proven and evidence-based protocols as well as measures to improve patient care, decrease costs, and demonstrate value to the market. At this stage, most hospitals are going to continue to have a mixed medical staff of both employed and independent physicians. Clinical integration now provides an alignment vehicle for hospitals to invoke the entire medical staff, both those that are employed and those that are independent practitioners. And in this type of paradigm, physicians and hospitals are now coming together to address the delivery of high quality and efficient care. And we'll go to the next slide. So the overarching goal of clinical integration is to promote a higher quality of care and more cost-efficient patient services by better coordinating care across the continuum of conditions, providers, settings, and time. So from the quality perspective, clinical integration is centered on information sharing and care continuity. The Joint Commission has cited communication breakdown as the single greatest contributing factor to sentinel events and delays in care in U.S. hospitals. By the same token, clinical integration is going to offset this with its emphasis on timely and clear communication. It's a means of eliminating duplicative diagnostic testing and reducing the risk of medical errors. Most medication errors, it turns out, are not caused by individual carelessness, but by faulty processes that lead people to make mistakes or to fail to prevent the mistakes. Clinical integration improves pharmaceutical management by allowing hospitals to identify gaps in the medication management process, and it allows them to take actions to help make patients safer. Clinically integrated care teams address gaps in the care continuum and reduce ineffective or unneeded process steps. This approach allows hospitals and providers across the system to learn to operate as a team to better align or to realign their efforts to improve quality, patient safety, and patient and family satisfaction. And finally, in terms of preventative care, clinical integration emphasizes wellness initiatives such as outreach programs and classes to educate patients and facilitate their own participation in their care, which ultimately has as its goal the creation of a healthier patient population. Receiving wellness and prevention advice from local hospitals and physicians really resonates with community individuals. So that's the quality perspective of clinical integration. But from a financial perspective, clinical integration can really reduce overall medical costs at both the patient level and at the community level. By making it easier for healthcare organizations to track quality and outcomes measures, this can increase pay-for-performance revenues. Physicians in a clinically integrated network can negotiate collectively for commercial payer contracts, which includes the associated hospital incentive payments for improving the quality of care and improving hospital efficiencies. As clinical integration improves the quality of patient care and processes and reduces costs, hospitals are really able to achieve market differentiation. And this type of differentiation is very attractive to healthcare plans and can serve as a catalyst for securing payer partnerships. Next slide, please. Clinical integration demands a governance body with strong physician leadership. And it's only this type of entity that is ultimately going to be able to create the clinical strategies that are required to pursue value-based contracts with commercial payers and develop innovative care contracts with employers. It's only this type of physician-led structure that can drive cultural change, with physicians now having to transition away from the fee-for-service mindset. This includes adopting new behaviors that align with outcomes-based reimbursement, such as collaborating across specialties, sharing information, managing utilization, and providing proactive care. Educating providers on clinical integration concepts, including innovative care delivery models and tracking of clinical quality outcomes, is what's going to allow community physician members to ideally understand the value of their own participation. And the next slide, please. The heart of clinical integration is really care coordination. And greater coordination between providers is going to improve patient outcomes and wring costs out of the system by optimizing care transitions, by reducing redundant testing, and by providing better management of patients who, in this day and age, have multiple complex comorbidities and diagnoses. a newly created hospital system or a new merging hospital system, ones that are able to foster this are really going to be able to meet the three prongs of CQO head on and optimize their chances for viability and sustainability in what is proving to be a very crowded market space. And that sums up our talk for today. I think we have time that we can open it up for questions or comments, or if anyone has any experiences that they'd like to share.
Fantastic. Thank you, Dr. Boehm and Jeff, for that great presentation. We will now begin today's question and answer session. Please submit any questions you have by typing them into the control panel in the space labeled Enter a Question for Staff and clicking Send. We will try to get through as many questions as we have time for. So it looks like we have a couple of questions over here. So one audience member asks, how large was the team on example 1 dedicated to making this happen within 8 months?
So I'll take that. There were a couple of questions people were asking about the type of resources and the amount of staff. So I'll go through each of the examples and give some thoughts on how much staff was involved or what it took to accomplish that. I would say, for example 1, there weren't a whole lot of people that were 100% dedicated to this integration. A lot of the people really took this as another element of their job, and really them being the subject matter experts in how things worked at the large academic medical center, it was up to them to sort of figure out how to integrate with the other organization. And I would say that happened for a lot of processes. There were some departments that integrated very quickly, especially in the finance side. I would say where there were a significant amount of resources was on the technology integration. If you think about what it takes to upgrade your technology or implement new technology, you had all of those same sort of issues that you would have with any integration. So the amount of staff, and it was really third-party consultants in a lot of cases, just because of the volume that was brought in to support that integration and that transformation was significant. And it wasn't just about the people that were doing the coding or the programming or things like that. Think about having to train basically almost every employee in a new organization on new systems, on new processes. And so in order to do that, you had to remove them from their environment. So the backfill needs and the additional training needs were really significant. And that was a monumental task in and of itself. Because in a lot of cases, the amount of change that was happening was not only about a new technology, it might have also been about a new process. So combining all of those changes. In example 2, since it's moving along at a slower pace and a different approach, and so there's not the integration of technology, there are people that have been removed, I'll say, from their day-to-day operations that are really mostly responsible for the integration activities and the alignment activities, and part of it is just helping to plan what the activities are. But there were a lot of consultants brought in initially to do financial review, and right now, because of they haven't decided when they're going to get married, they're still in this long engagement period, they're just slowly trying to incorporate as much as people can in their normal day-to-day. The people that they have added or have resourced to this project really focus on the project management type of activities.
Fantastic. So we actually have a quick follow-up on that. The audience member also wanted to know the size for those 2 examples, for the teams for those 2 examples that you gave in full-time equivalents to FTE.
The number of additional full-time equivalents for those examples? I would have to go back and pull that information because, like I said, they didn't necessarily add additional staff, but there was a lot of usage of agency nurses when they were training the agency nurses. There was a lot of uses of consultants to do the additional technology implementation. I will say, though, that because of the the care protocol and the way that they were delivering care and the infusion of additional financial resources, the community hospital was able to hire more specialists and more caregivers than they had historically. So there was actually an increase in the number of FTEs in the sense because they felt they needed it to bring up as they were introducing all these new clinical processes to be able to support these new clinical processes.
Okay, fantastic. So that's actually all the time that we have for questions. Do you have any closing remarks, Dr. Baim and Jeff?
No, I don't think
I was just going to underscore that I think that, you know, that this is a topic that is particularly relevant and that we're going to be seeing more and more. And so I think, you know, the teaching points from today, as well as experiences with hospitals that are going through this, is really going to kind of provide a template or a framework going forward as we kind of learn about the changes, kind of learn as we go, because I think we're going to be seeing more and more of these types of integrations happening really across the country.
Yeah, and I would just add that I think it's important for people to evaluate how they're going to support these clinical integrations and the importance of that, because in our experiences, the physicians and the clinicians and the caregivers really want to standardize the way that they do things and really want to get the benefit of clinical integration, and it's up to the rest of the organization to help provide the infrastructure to support that.
Fantastic. Well, that is all the time we have for today. I would like to thank Dr. Baim and Jeff for their excellent presentation and to our audience for participating today. Enjoy the rest of your day, and we look forward to having you join us for future endeavors.